Good morning. Yeah, it's still morning. I'm going to talk today primarily on obstructive sleep apnea. They had me down originally for sleep disorders, but that's like talking about all of cardiology in an hour. Kind of difficult to do. So, any goal on talking to somebody about sleep is to talk to you and educate you on sleep without inducing it. But I hope to convince you that obstructive sleep apnea is a common problem, has significant effects on your life, and is very treatable. Let's begin first with a case study. Anybody know who Reggie White was? Played for the Green Bay Packers, basically Defensive Player of the Year twice. I'm not sure if he was an ordained minister, but he was a very religious man, fellowship, a Christian athlete, so he was known as the Minister of Defense. To quote Brett Favre, he is quite possibly the best player he ever saw and ever played with or against. And unfortunately, Reggie died at 43. He had severe and untreated sleep apnea, and he was felt to have died from a heart arrhythmia related to sleep apnea. Untreated sleep apnea is felt to represent about 38,000 deaths a year in the United States alone. So, what is sleep apnea? Apnea is Latin meaning for without breath, and sleep apnea is obviously apneas that are occurring when a person is sleeping at night. The American Academy of Sleep Medicine defines sleep apnea as occurring for greater than 10 seconds at a time. It's kind of the standard definition we use. We grade how bad sleep apnea is by what's called an apnea-hypopnea index, or some labs will call it a respiratory disturbance index, RDI. And that's basically how many times an hour the sleep apnea is occurring. Apneas are complete obstruction of airflow. Hypopneas, or basically a drop-off in airflow, it pretty much does the same thing to you that sleep apnea does, so we kind of lump them together. We, in general, define 0 to less than 5 times an hour to be normal, 5 to 15 times an hour in my lab to be mild, 16 to 30 to be moderate, and 31 and up to be severe sleep apnea. This number seems to correlate best with health outcomes. In other words, some people are concerned that they stop breathing 40 times an hour. Well, that's probably less hard on your heart than if you do that 4 times an hour as somebody that stops breathing for 10 seconds and does that 60 times an hour. What goes on with sleep apnea? Why do people that have this do this? To understand that, we have to look at how we breathe. When we take in a deep breath, we create a negative pressure in our chest, and that pulls air in through our windpipe, and it flows over the surfaces of the upper airway, especially behind the tongue and the soft palate there. When air flows over any surface, it creates a negative pressure. Same thing of air going over an airplane's wing makes it fly, and that's called Bernoulli's principle. Now, you obviously understand that we're not having apneas right now, even if you have sleep apnea, and why is that? And part of that reason is the body, when you're awake, pulls the tongue forward and keeps the airway open. But when we drift into sleep at night, if you're prone to sleep apnea, the muscles of the upper airway relax, and the airway narrows. Here you can see it narrowing from there to there. And that often causes a vibration of the upper airway tissues, and that results in snoring. If it narrows even further, there's a complete obstruction of the airway. The walls basically get sucked shut. Now, the sleeping brain is kind of on autopilot. It's just responding purely to chemical signals and doesn't realize the upper airway is blocked. So when this occurs, the brain just simply sees a dropping oxygen level and says, oh, I need to breathe more. And so it tries to breathe against this blocked airway. And after a period of 10 to 40 seconds, at the end of that time, the brain says, hey, I better do something here. Goes from nice restful sleep to almost awake. The tongue's pulled forward, air flows, everything is fine. But one, a person's sleep is disrupted. And then two, if we measured your blood pressure on a second-by-second basis, we would see it kind of skyrocket up with one of these events. And then the dropping oxygen level and then going back up again, we think promotes a tendency of blood vessels to constrict, what we call vasoconstriction. This happens a time or two a night, not a big deal, but if this is occurring repetitively over and over again, that kind of pounds the circulation over time. Why does this happen? Is this purely an anatomic problem? Well, to look at that, some folks have done MRI scans of people with sleep apnea and those without it. And when they did a comparison between the two groups, what they found was people with sleep apnea tended to have larger tongues. You can kind of see that there compared to a normal person. But interestingly enough, the side walls of the upper airway behind where the tongue is tend to be a little bit larger in somebody with sleep apnea compared to somebody without. So in general, the upper airway is smaller. It's kind of hard to see this slide didn't project very well, but here's a control group person that has a kind of wide lateral, and then here's somebody with sleep apnea, kind of rounder and a narrower airway, especially in the lateral dimension. So we got a narrow tube, but we also tend to have a floppier tube. Folks with sleep apnea tend to have a higher fat content in the walls of the upper airway, and that makes it more collapsible, more compliant. Also, the repetitive episodes of obstruction tend to lead a person to having edema, kind of swelling of the tissues, and that makes it more collapsible as well too. Most people that have sleep apnea are kind of bigger people in general, and so they have a higher body mass, and that's not necessarily obesity, just big people. And in that case, they have a greater metabolic demand. Not only do we breathe in oxygen, but we breathe off carbon dioxide, and so they need to move more air in order to do that. And so more airflow, kind of a higher collapsibility across the upper airway. But that's not all that's what's going on. There's also reduced muscle tone of the upper airway. And people with sleep apnea, they tend to relax their airway a little more, letting it collapse, even when compared to people without sleep apnea. They've done some studies that probably aren't worth going into here, but when they've looked at, is this purely an anatomic problem, or is this a muscle relaxation problem? About 60% of what's going on is the muscles relax farther. So now that you know what it is, how common is this? And the folks at the University of Wisconsin did a study on this. What they did was they got about 600 state employees. They didn't do any screening. They didn't ask them if they snored or if they were sleepy or stopped breathing during sleep at night. And they basically just did sleep studies on them and see how common this was. And they found that in men, about if you define sleep apnea as stopping breathing 15 times an hour, that's what we would consider to be the division between mild and moderate in my lab. That's 9% of guys and basically 1 out of 20 women. And if you lower the bar a little bit further, 5 times an hour, which still can make a difference in some people, basically 1 out of 4 guys and 1 out of 10 women. So what percentage of folks that have sleep apnea have been diagnosed? And the answer is not a lot. It's probably on the order of 11 to 15%. So that means about 85% of people that have sleep apnea have not been diagnosed. And that's about double what it was when I started my training, but we've still got a long ways to go. So if you have sleep apnea, why is it bad for you? Well, there's a couple different reasons. It can have an effect on your quality of life. It can have effects on your health by decreasing the ability to think. Excessive sleepiness can put you at risk for car crashes. And I'm going to try to convince you that it's a risk factor for various different types of disease, especially in the cardiovascular realm. Quality of life. People with sleep apnea tend to have when you do studies looking at a person's basically quality of life surveys, there seems to be a correlation with the worse your sleep apnea is, the lower the quality of life. And that tends to occur in the energy and vitality scales. People with it tend to feel less energetic. They tend to feel less vital. Spousal problems, as much as we joke about this, this could actually cause a significant sleep disturbance in your wife's sleep as well too. People with sleep apnea tend to be able to think less effectively. That's all sort of shown in a variety of different studies here, but to break it down, people with sleep apnea tend to be less alert. They tend to have decreased attention, ability to make decisions on planning and organization, and actually do worse with spatial motor tasks. And you're more prone with sleep apnea by about 220% to have an industrial accident or so, even when controlled for other common variables that are associated with these accidents. And this can occur whether you have a white or blue-collar job. Let's talk a little bit about motor vehicle crashes. People with sleep apnea tend to have higher incidences of this. You stop breathing 5 times an hour, you're 3 times as likely to have multiple motor vehicle crashes, and 15 times an hour, you're 7 times as likely to crash your car multiple times. Crashes with sleep apnea tend to be disproportionately severe. In other words, you're driving in traffic, some idiot cuts you off, your adrenaline's going. That's not when you're going to fall asleep. It's when you're on the highway, your cruise control's on, and you're moving at faster speeds. The road turns, you don't, and the chances of dying is about 4 out of 5 here. It's felt to represent about 1,400 deaths a year as a result of falling asleep at the wheel. And somebody did an analysis. They thought about $16 billion a year are used to take care of folks that had motor vehicle crashes from crashing their car while falling asleep. Yes, sir.
Just because you're tired from not sleeping, so you're tired every day?
Yeah, because your sleep is disturbed at night, so we think that's kind of the main feature to it. Also, reflexes are a little slower, so if some idiot jams their brakes on in front of you, your ability to stop in time is a little bit less, that sort of thing. But sleep apnea also seems to be statistically associated with medical illnesses, and most of them are in the cardiovascular realm or so. And for a long time, a number of physicians, especially the British, were prone to say, well, that's because they're overweight. That's because they've got high blood pressure. And they didn't think that sleep apnea itself caused illnesses. Well, I think there's fairly convincing evidence that sleep apnea in and of itself can cause medical illness as well. You need multivariate analysis in order to sort this out, and very large epidemiologic studies to look at this. And the one I just want to touch on is called the Sleep Heart Health Study. This was by the National Heart, Lung, and Blood Institute. It was looking at basically a number of patients that are already being followed as part of studies for blood pressure. So they already have data on these folks from these studies, where they can tell us that, if your blood pressure is 130 over 70, you've got double the stroke risk of somebody that's 110 over 60, even though neither of those are hypertensive, by the standard definition. But anyway, they know precisely all these folks' cardiovascular, standard risk factors, cholesterol, blood pressure, family history, that kind of thing. And what they did is a fairly colossal thing. They did sleep studies on about 6,400 of them. And they just randomly selected them, so some were going to have sleep apnea, some weren't. And then they were able to do a comparison between people that had sleep apnea and risk factors X, Y, and Z for heart attack and stroke, and compare them with the same risk factors but had sleep apnea, and were able to get a good idea, what the chances were that they've already had a heart attack or stroke. And lo and behold, it seems to be elevated in people with sleep apnea. Look first at the effect on high blood pressure. What they did is they broke it down, and how many times an hour a person stopped breathing. As you can see, as more times an hour they stop breathing, the higher the odds are that they've already got high blood pressure, about 3 times as high with moderate sleep apnea or so. This is a little bit confusing slide, but let me sort of just explain it a little bit. On the bottom of each of these 4 graphs is how many times an hour you stop breathing. 0 is normal, 50 is pretty severe sleep apnea. And this is a logarithmic conversion of basically risk, but think of it, the higher it goes, the higher your risk is for things. And what this does is looks at overall cardiovascular illness, your chances of having a heart attack, heart failure, and stroke here at the bottom. And what you can see is your overall risk of cardiovascular illness goes up. This is kind of interesting to me. By about 10 times an hour, you have an elevated heart attack and stroke risk, which is what I would consider to be mild sleep apnea, but that's pretty much the same risk as somebody with severe disease. It's a little different for stroke here. Basically, the worse your sleep apnea is, the higher your risk for developing stroke is. And the overall effect is about a 30% elevated risk of heart attack and stroke. That's about equivalent to somebody that has high cholesterol. So hopefully I've convinced you that sleep apnea is common. It can have some very significant effects on your life. How do I know if I have this or not? And the first of which is to see a physician about it, and they should ask you basically on symptoms. The first of which is snoring. Most patients with sleep apnea snore, and this is kind of interesting. That they describe snoring that somebody with sleep apnea has is heroic. In other words, no mere mortal can produce snoring this loud. You need to be Hercules or something along those lines. But this tends to be quite loud. I've had folks that, typically you can hear it through a closed door. I've had a lady that was a shift worker, and she could hear her husband from about a block away sleeping at the house as she walked down the street. So that's probably the loudest I've heard. One little caveat here is absence of snoring does not equal absence of sleep apnea in somebody that's had upper airway surgery. That surgery is very effective at knocking out snoring, not so effective for knocking out sleep apnea. Witness apneas. Usually the bed partner notes that the person with sleep apnea is having periods where they're not breathing, and typically the one associated with obstructive sleep apnea looks like they're struggling to breathe but not moving any air, and then classically it'll terminate with a snort or a gasp or something like that. Most patients with sleep apnea are not aware of doing this, but the more severe patients are. In other words, if you're waking up with snoring yourself awake or choking and gasping on a regular basis, that's pretty predictive that you're going to have sleep apnea if we do a sleep study. Other symptoms, dry mouth and sore throat are quite common in people with sleep apnea. That's just from the heavy snoring. Headaches can occur in the morning in people with sleep apnea, and these are often associated with bloodshot eyes. Typical symptoms that it's sleep apnea causing the headache, because you can have nocturnal headaches from other reasons, is it goes away spontaneously. It's gone by like 10 in the morning, as opposed to you need to take Tylenol to knock it out. And it's often associated with those bloodshot eyes. And the reason for that is when you're under breathing during sleep at night, not only do we have lower oxygen levels, but we breathe out carbon dioxide, kind of a waste product made from metabolism. And if you're not breathing it out, the blood level goes up, and that causes the blood vessels in the brain and eyes to dilate, and that results in the brain swelling, which is what causes the headache, but also the bloodshot eyes. Night sweats. I was taught in medical school that if a person wakes up at night drenching their sheets, the bedclothes, that kind of thing, that's a sign of tuberculosis or lymphoma, lymph node cancer. And it can be those things, but I'll tell you the most common cause in the United States of that sort of thing is the sleep apnea. In other words, a person's drenching the sheets because they're giving off these bursts of adrenaline when they're waking from these apnea episodes at night. Excessive daytime sleepiness. This is a common complaint in people with sleep apnea. Some caveats here is, when we talk about excessive daytime sleepiness, that implies that there is a normal level of daytime sleepiness. In other words, if you fall asleep watching the game on the couch on a Sunday afternoon, that's not abnormal. That's kind of a normal thing. Most people do feel a little sleepy in the afternoon, especially right after lunch. There's other reasons that a person can feel sleepy in the daytime. I think the most common sleep disorder in the U.S. is actually burning the candle at both ends, insufficient sleep syndrome. We're all too busy to sleep. Shift workers, it's very common around here at some of the plants that folks will work 3 days, off for 36 hours, 3 days of nights, off for 36 hours, and then back again. I couldn't do that, but that can make a person sleepy. And then just really bad sleep habits, or what we call sleep hygiene, can influence a person's level of sleepiness as well. So some rough levels to sort of guesstimate. If you're falling asleep while watching TV or reading a book, that's normal or a mild level of daytime sleepiness. If you fall asleep in circumstances where you're at a movie theater or something, folks are gonna laugh at you if they look at that guy sleeping over there, or falling asleep at work, your boss is going to yell at you for falling asleep. I would consider that to be moderate level of sleepiness. And then severe levels of sleepiness are folks that fall asleep while they're eating, while they're in conversations with people, and then although a long drive can be kind of sedentary, the consequences of falling asleep while driving could mean your death. So there's a seat over there if you want it. But, so I would consider that a severe level of sleepiness. A couple caveats: just because you don't consider yourself to be excessively sleepy does not mean that you don't have sleep apnea. There are some patients out there that stop breathing 80 times an hour, and I see them in clinic and they say, "Doc, I use this CPAP machine to treat my sleep apnea. I know it's good for my heart, but I don't feel any better." And I flip back through their chart, and they weren't sleepy in the first place. On the other hand, I've got a gal that's in my clinic, stops breathing 5.2 times an hour, barely even qualifies as having sleep apnea. And I saw her back, after I put her on a CPAP machine. She was quite sleepy, and she's cradling the thing, going, "You're not taking this away from me. This thing works really good." So, there's an imperfect correlation, and I think some people, even with very mild disease, can get a significant benefit from these devices. On the other hand, those with severe disease that don't feel better, I still think we're reducing their heart attack and stroke risk. So let's say your doctor has determined that you do have concerning symptoms for sleep apnea. What's next? And that usually is the sleep study or polysomnogram. The sleep lab that I run here is at Our Lady of the Lake. It's in Tower 1. We're a 4-bed accredited by the American Academy of Sleep Medicine, and we take most insurance. Usually folks get there around 8 or 9 o'clock at night, and then you're home and out for work the next morning. It's technically an outpatient procedure. That is, people are not admitted to the hospital. And we try to do what are called split nights, which is when you come in for your sleep study, we spend the first half of the night just looking at you, but if it's pretty clear cut that you've got sleep apnea, then the second half of the night we get you on treatment, and we'll do that with CPAP, and we'll cover what that is in a second. Although we try to do this, it's not always possible. Some people, the first night in the sleep lab, sleep very poorly. We call that the first night effect. It gets better, more time in the sleep lab. Some people have concomitant insomnia. They just don't sleep well, period. And I've kind of taken to giving my patients a sleeping pill the night of the sleep study in order to facilitate sleep. That's kind of a change from what was done in the past, but I've had people that have classic symptoms for sleep apnea, and then they get a sleep study done and it's come out negative, doesn't show any sleep apnea, and we repeat it with the sleeping pill, and all of a sudden they got severe OSA. I think it was they just never got into deep enough sleep to show their true degree of sleep apnea. What happens with the polysomnogram? We basically wire you up. We use gel to attach electrodes to the scalp. We've got a little thing that goes around the nose like oxygen tubing, but instead of giving you oxygen, we measure your breathing in and out. Little microphone on the neck for snoring. Those things on the chin are looking at muscle tone because it goes down, should be about nothing in REM sleep. EKG, oxygen finger probe, bands around the chest and belly to measure expansion and contraction of the lungs and belly while you're breathing. Now, a lot of people say, well, how do you use the bathroom if you have to get up in the middle of the night for that? And it's actually can be a fairly common problem. And all these wires go into what we call head box, and you can just disconnect that and bring it into, bring it with you and reconnect easy enough. It's not painful. Never had a patient complain of pain after a sleep study. What do we look at? What do we see on the screen? And this is an example when we're looking at it. Just to put it in perspective, these are your eye movements. These are the brain waves, the muscle tone, EKG, and this is a 30-second period of time here. Down here, we've kind of compressed the time. This is more about, I think it's about 4 or 5 minutes. And what we're looking at is the snore microphone, the airflow, the effort from chest and belly, your oxygen level, and then we even look at the legs, because some people will kick their legs during sleep at night. This is an example of somebody with severe sleep apnea. That's nice restful sleep here. You see it get a little busier there. The muscle tone goes up. And that's what we call an arousal. Person is waking from sleep at night, and that's occurring after this apnea here, where you see their breathing. It's kind of obscured by the snore microphone, but it's nice breathing, and it goes to flat line, but you still see effort. They're attempting to breathe, and then you see their oxygen level drop and go back up again. These leg kicks are kind of a disorder in and of themselves, but often a person with sleep apnea will do that as well. So once we find out that you have sleep apnea, what do we do about it? Well, there's a couple general principles. In general, we recommend avoidance of sedatives, alcohol, because the reason why we're not having apneas right now is because we're pulling our tongue forward. Most sedatives, like Ambien, something along those lines, are muscle relaxants. So in theory, they can make the sleep apnea a little worse. You can't get away seeing a talk from a pulmonologist without a plug on smoking cessation here, but not only can smoking cessation do a lot of things to reduce your heart attack and stroke risk, but the smoke irritates the upper airway, and that can potentially worsen sleep apnea as well too. What doesn't work? Over-the-counter remedies, the Breathe Right strips, the snoring sprays. They may have some effect on snoring, but in general does not help with a person with their sleep apnea. Now, tonsillectomy, although it's the procedure of choice for pediatric sleep apnea, and yes, kids can get this, and in fact, they used to die from this about 100 years ago. And it is the treatment of choice for pediatric sleep apnea. There's little effectiveness in adults, and the reason for that is the obstructions occurring behind the soft palate and behind the tongue, and the tonsils are really kind of right in between places. So. Yes, sir. Adenoids are a collection of basically immune system cells up in the nasal cavity, and tonsils a little bit lower down in the back of the throat. So if you get a TNA, tonsils and adenoids, that takes out both of those. So weight loss. The effect is not predictable. My background was an Air Force sleep physician, and I had guys that were thin as rails. That had very severe sleep apnea. I had an Air Force pilot stop breathing 168 times an hour. That's actually my record. And he was very thin. He'd go running a couple times a day. He just happened to be retrognaathic, a little bit recessed jaw that kind of narrowed the back of the airway there. There's a variable response to weight loss. You're never going to get a physician to tell you not to lose weight outside of a cancer clinic or anything, but the effect is variable. Let's talk a little bit about bariatric surgery. That's there are a bunch of different surgeries out there. The gastric sleeve, being a common one, that cause fairly dramatic weight loss on the order of 70 to 120 pounds. This can often improve sleep apnea, get you about 60% of patients can be cured from this, but there's a couple things we worry about. Just because you've lost the weight does not mean it's cured. I just saw a gentleman yesterday that had lost 127 pounds after bariatric surgery. Went from like 370 down to about 250 and had done very well with that. But unfortunately, we did a sleep study and he was not cured. He still had moderate sleep apnea. And believe it or not, people that have had weight loss surgical procedures can often regain the weight and then the sleep apnea can come back. So I would recommend not doing this for just sleep apnea by itself. What does work? Positive airway pressure modalities are probably the treatment of choice. However, not everybody can use this. And so there's other therapies that can be used, including upper airway surgery, a mouthpiece, a dental orthotic, positional therapy, where we have a person sleep on their side and not their back, and then combinations of the above. In my opinion, the ideal therapy is personalized to the patient, depending on if they have any anatomic abnormalities or how severe their disease is. Let's talk first about positive airway pressure, or CPAP. This stands for continuous positive airway pressure. For some reason, a lot of folks say CPAC. That's not I don't know where that comes from, but it stands for continuous positive airway pressure. And it's really the treatment of choice for sleep apnea. This device was developed in the 1980s, so it's been around for about 30 years or so. And the way it works is it's a little box that sits on the bedside table. It's connected via tubing to a variety of different masks. And what it does is basically it's a little blower, and it's got a little servo that detects, if I say set it to 8 centimeters of water, that would blow a column of water 8 centimeters high. And when you breathe in, the pressure drops, so the little fan speeds up, the pressure goes up. You breathe out, the pressure goes up, so the fan slows down a little bit, and it kind of continuously maintains a pneumatic splint to hold the airway open. Most studies that show that most studies that show that we can treat sleep apnea are based on CPAP, so I would consider this the best proven effective therapy. There's hundreds of different masks that a person can use to connect to a CPAP machine. We have the standard nasal mask, which goes over the nose there, but doesn't cover the mouth. We have nasal pillows, which are little things that just kind of sit in the nasal opening. The Swift here, or the nasal air, is kind of like a giant oxygen tubing. There are 2 examples of that, and they're good for patients that have trouble with claustrophobia. The full face mask you see here is pretty good for people that have really blocked up noses, can't breathe through the nose, and you kind of bypass it by getting the air in through the mouth that way, though not a good choice for claustrophobia. There's different types of positive airway pressure. CPAP is the most common. That's the simplest machine, but BiPAP is another commonly used one. You get one pressure with breathing in and usually a lower pressure with breathing out. This was developed by the Respironics Corporation in an attempt to help people that had trouble with tolerating CPAP, and they did some real good science on this, great statistical analysis, and they proved that this is no more well tolerated than CPAP is. So they kind of shot themselves in the foot. But I still think this does have a role. It can be useful in people that have trouble with when you ask them why they're having trouble with the CPAP machine, they have trouble breathing out against the pressure. It can be helpful. And then if you have lung disease like emphysema at the same time, it can make a difference. APAP, or automatic positive airway pressure, is new therapy, and we're not exactly sure where this fits in yet. It's a smart CPAP machine. Think of it as your own sleep technologist that's monitoring you on a nightly basis. Starts you at a real low level, and when you fall asleep, if it detects an apnea, it goes up a little bit. Detects snoring, goes up a little bit more. And then if you haven't had any apneas, after about 20 minutes, it drops. You have another one, it goes up again. So it's kind of actively homing in on the right pressure for you. This is useful in some folks. I've had some people that don't tolerate CPAP that do well on this. And then the ASV is a very smart CPAP machine. It's kind of beyond the scope of this talk. What's the role for CPAP? There's basically very few contraindications to it. Folks that have had surgery on the pituitary gland where the neurosurgeon goes up the nose, drills it out, and there's a connection between the brain and nasal airway, that's pretty much the only absolute no-no. And then that even, I've had neurosurgeons say it's okay to use as short as a month after they've had neurosurgery. That's basically our only contraindication to it. It's a very safe machine. Relative contraindications is people that keep getting, infections of their sinuses over and over again. It just becomes a problem at that point. It really is the treatment of choice based on that it has the best effect on your overall health and daytime functioning. Because we can take somebody that stops breathing 160, 170 times an hour and get them down to 0 times an hour with one of these devices. Completely knock out their snoring. CPAP has some complications, but they tend to be treatable, if you will. Most people that use it have masks on their, mask marks on their face. They go away throughout the day. Some folks will have pain at the bridge of their nose or some skin breakdown, nasal congestion, ear pain, runny nose, that kind of thing. But this is generally treatable. And so what I find for getting somebody successfully on CPAP is finding a good home care company. And admittedly, these guys are not created equal. There are some out there that'll give you the machine, say good luck, and that's all you get from them, and other folks out there that'll work with you and try to address these problems. Then I tend to refer my patients to folks that do well with this. They found that addressing problems quickly is one of the best ways to prevent having trouble with it. If you use CPAP, then your habits on use of it are generally established within about the first 4 days. So what I usually tell my patients is if there's anything bothering you about it the next day, call the home care company and have them work on it. If that doesn't work, give me a call. I'll also give them some educational material on how to do well with it. I usually follow these patients up quickly. I don't see them back, 3 months later. I'm usually seeing them back in several weeks. I try to address the problems as quickly as possible. And here's where I think a lot of the medical profession has kind of fallen down on the job. If a person doesn't do well with CPAP, the simple question, I try to teach this to the residents, is ask them why. And see if there's something that can be done about this. A lot of docs are, okay, not tolerating CPAP, DC CPAP, and moving on. Smart cards are kind of a little interesting thing that we do on follow-up on our patients. And this is just to make sure that the patient is using the CPAP. Insurance is out there. Medicare, I think Blue Cross, basically requires a person to use the machine in order to have it paid for. And I think that's totally fair. When I was in the Air Force, we would see guys that had probably had sleep apnea for 20 years, didn't get it treated because they were afraid of what it would do to their career. But then they, before they were about to get out of the military, they would get the machine and then they'd move to somewhere else in the country and they had no follow-up. And usually they'd have trouble, they'd put it up on their shelf and it didn't do any good. So, not a real effective therapy that way. Won't work if it's not used. And so Medicare's criterion is you have to use it a certain amount of time at night in order for them to continue to pay for that. And I like seeing these smart cards as well too, because I know that if you're not getting the adequate dose of sleep, of CPAP, your heart attack and stroke risk is not reduced. We're not doing you any favors. So what do you do if you can't tolerate CPAP? A lot of people, or I shouldn't say a lot, a percentage of people, after they tried CPAP, they tried everything, they can't do well, then what can you do then? Well, we usually advocate that conservative therapy, avoid sedatives, exercise, weight loss. But there are a couple other things that can be looked at as well too. Let's talk first about dental appliances. Most common one of these is the mandibular repositioning device. That's shown in these slides here. That's very similar to like a football player's mouth guard. You go to the dentist, they make you one, you sleep with it in place, for a week or two, and then you come back in, they advance the lower jaw slowly until you get full protrusion, and then they back it off slightly and they make you a permanent one there. This works by treating anatomic obstruction primarily behind the tongue, which is the ideal place because most obstruction is occurring there in most people with sleep apnea, about 90% of them. And it's also a reasonable treatment for snoring as well. Unfortunately, it's not so good for severe disease. So if you have severe sleep apnea, it's not going to get you completely resolved with that. People don't always use this 100% of the time either. Some contraindications for it is if you have temporomandibular joint pain, that's a pain in the jaw here, or if you have very loose teeth, dentures, that sort of thing. Every dentist I've ever talked to tells me that they can make me one of these devices, but I'm not certain that every dentist does this well. There is a kind of a organization, the American Academy of Dental Sleep Medicine, that has training programs on this and a certification process. And last time I looked, there is not a ADASM dentist in Baton Rouge, but there are a couple that are training in the process for that sort of thing. So I would try to get over to one of those if you can. I also want to recommend that once you have a formal one performed, that you make sure it's working. Even though you're feeling better, that may not absolutely rule out that the sleep apnea is controlled. I had a gentleman that stopped breathing 10 times an hour, did not use CPAP, wanted an orthotic. We got him one made, felt better on it, but then we did a repeat sleep study on him, and he had gone up to 30 times an hour stopping breathing. So probably not the ideal treatment for him. There are some surgeries that are used for sleep apnea as well too, and they're broken down into palatal ones that work on the soft tissue in the back of the throat, and then in the next slide I'm going to show you other surgeries that can be done for it. Palatal surgeries, there's a bunch of them out there. The most common one is the uvulo-palatopharyngoplasty, or nobody can pronounce that, so we say UP3. And that's where they trim up the back of the throat here, take off that little flap that drops down called the uvula, and just sort of decrease the amount of soft tissue there. That's obviously in-hospital procedure. The layup or laser-assisted uvuloplasty is basically zapping your back of the throat with a laser. That is not recommended for sleep apnea because it doesn't work. And then finally, one that's gotten a lot of press lately is the pillar procedure. And this is illustrated in the bottom one there. An ear, nose, and throat physician can come along and insert these little silastic rods in the back of your throat there. This stiffens up the palate, makes you, in theory, less likely to snore, and it does have some benefit for mild sleep apnea cases. The advantage to this is it's an office procedure and it can be removed. I guess they can go there and pull these things out. Drawbacks of upper airway surgeries, they tend to be irreversible with the exception of the pillar procedure. Also, some of the complications, velopharyngeal reflux, which is basically when you swallow, stuff goes from the back of your throat, not down the food pipe, but up into the nose. And VP stenosis, we have a connection between our nose cavity and the back of our throat, and that allows us to drain secretions there. And I've seen some people scar that off, where they basically don't pass any liquids through there, and they basically have a continual running nose. It's quite a problematic thing. That doesn't happen in a lot of people, but I've seen some of these complications. One point I want to make on these palatal surgeries is they're very good at stopping snoring, but they don't do much for apnea, and I'll cover more on that in a second. Other upper airway surgeries, there's the GAM, or genioglottal advancement hyoid myotomy, which is where they take a little piece of bone off the front of your jaw that's connected to your tongue, pull it forward, and then reattach it to your jaw. So it pulls, since your tongue is attached to your jaw and that's been moved forward, it opens the space behind your tongue a little bit. They also loop a little thing of muscle flap around your hyoid bone down lower and pulls it forward as well too. The BIMAX, or mandibular maxillary osteotomy, is a fairly involved surgery where they cut your jaw in half about right here, and then with a spacer they move it forward, and then since your teeth wouldn't line up, then they break the maxilla, which is part of the skull right here, off, and they slide it forward there. That sounds like something that's quite medieval, but and this is actually probably one of the more effective surgeries. The problem with surgeries is they haven't been studied that well, but my wife, she's a physician as well and was in the Air Force, and Air Force pilots are not allowed to fly jet fighters and the like with if they're on CPAP, if they have sleep apnea. So, and these guys will go through anything to keep flying again. So we've had guys that went through all 3 surgeries, and they said the recovery from this surgery to a man is easier than having the back of your throat cut on. So that's not a scientific study, but a lot of guys thought that it's pretty easy to tolerate, although it does look kind of horrific. This one, if you ask me, this has probably got the best chance for surgical care in people with sleep apnea. But that's often in people that have a little retronathia, the jaws kind of push back a little bit. Other measures that can be looked at. This is new, so we don't have a lot of experience with it. This is called Provent. These are little stickers that have a one-way valve on them, and they're put over your nose. And what happens is you breathe in fine, but when you breathe out, there's some resistance. And so that back pressure kind of acts like a CPAP machine, kind of holds the airway forward. They've done some studies on these, and not surprisingly, they're helpful in mild to moderate sleep apnea, like a lot of things. Probably don't work so good for severe sleep apnea. I haven't seen the patient's back I've put these on yet, so I don't know how well they're working. These just came out. I just got some samples a couple of weeks ago. Yes, sir. Well, there's occasionally you can put a chin strap on, just a little rubber band to keep the mouth closed, that sort of thing. A lot of people learn to keep their mouth closed during sleep at night, with the CPAP machine on, because a lot of the air pressure is delivered through the mouth, and people can have air leaks from it, but a lot of people just get used to sleeping with it that way. So, yes, sir. We'll cover that at the end. How about it? So, yeah. So positional therapy. This is kind of a device to keep a person off their back, and this is for people that have positional sleep apnea. In other words, when they're on their back, they got a boatload, but when they're on their side, they stop breathing less than 10 times an hour. This is the Z-Zoma device. It's the only, to the best of my knowledge, commercially available device that you can buy that keeps you off your back, if you will. The tennis ball sewn into a pocket. It was actually invented by the wife of a sleep apnea patient, just on the observation that she saw when her husband was on her side, was on his side, he did well, and she sent it into the Mayo Clinic, and they were so impressed with her they published it in their medical journal. But it works well. The one thing to this is when I've recommended this to patients, they're going, I don't need that, doc. I never sleep on my back. But I've had I'm never aware of sleeping on my back at all. I've had some sleep studies on myself, and about 30% of the night I'm on my back. So, but this can be helpful. I recommended this the other week. Does any of this stuff work? Well, to answer that question, we need to look at the goals of therapy, and they are to knock out your snoring, because that can sometimes drive the spouse insane, eliminate excessive daytime sleepiness, and more importantly, reduce your risk of death. Let's look at CPAP here. It's very effective in knocking out snoring. It's probably the most effective therapy out there at eliminating your daytime sleepiness, and it can reduce your risk of death. This is an interesting study they did in Spain. They had about 10 sleep labs around Spain, and they would basically have folks that come in for a sleep study. They would classify them as whether they were just normal people, whether they snored, whether they had mild sleep apnea, severe sleep apnea, and they did nothing about it, or severe sleep apnea and they used a CPAP machine. They basically called them up every 6 months and basically asked them, have you had a heart attack or a stroke? And are you dead? That sort of thing. And this is the fatal heart attack and stroke risk here, and this is the non-fatal. And what you can see, this top line here is untreated severe OSA. This is the percentage of people that had that. And more importantly, this is treated OSA here. It doesn't get you down to zero, but you can see there's a very statistically significant difference in risk of heart attack and stroke. It's even more so with non-fatal events. And it's basically about, it looks a little higher, but statistically it's not different from somebody that has simple snoring or no sleep apnea at all. There's substantial reduction in heart attack and stroke rate. As you can see, here's people with mild to moderate disease. It's not quite as clear cut that we make a difference in heart attack and stroke rate with that, but I would do it for a family member. This is another study. This was out of Henry Ford Hospital, and this was kind of in the early days of sleep medicine. And what they did is they looked at your risk of death, and they compared it to age, controls, and they looked at CPAP. They looked at tracheostomy, which I didn't touch much on. It's basically a plastic tube that goes into your windpipe and basically bypasses the areas of obstruction that a person has. So it is very effective. I probably treated 10,000 plus sleep apnea patients. I've done this on one guy. Because I've had patients refuse this, but But what they showed in this study here, you can see this, risk of death basically negligible with trach, with CPAP, compared to, and so it made a difference in risk of death with controls. Upper airway surgery, that UP3, trimming up the flap, the palatal surgery in the back of the throat, you see there's no difference in risk of death with that surgery. So does that mean that only the CPAP and trach work? And the answer to that is probably not. We previously had an assumption that if your snoring goes away, you're cured, your sleep apnea is done. No snoring equals no apneas, and that's probably incorrect. Probably many patients, especially with severe disease, that got the palatal surgery, they stopped snoring, they were probably not cured. Ed Weaver is an academic ear, nose, and throat guy out of the University of Washington, and he's got some data showing that in people where they did get a surgical cure after that, there was a significant reduction in risk of death. So the take-home points with this is you want to verify that the treatment worked, and you want to do it by a sleep study. Elimination of snoring does not equal elimination of sleep apnea. So in summary, snoring and sleep apnea are a very prevalent condition, and at least the sleep apnea anyway, is not a benign condition. The current status in circa 2011 is diagnosed by a sleep study as an inpatient. The ideal treatment for that is CPAP, but there are other options for those that are not able to do well with it. Thank you.